You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. In part one of this two-part series, we use the routine vaccine schedule as our guide to walk us through the first half of the dreaded 13, discussing how to recognize and manage vaccine-preventable illnesses from hepatitis B through rubella. If you haven't heard part one yet, I encourage you to go back there first and come back and join me for part two of vaccine-preventable illnesses, varicella through meningococcus. Varicella is usually obvious, and it's usually benign, unless it's not. After an incubation period of about 2 weeks, school-age children will get fever and pharyngitis, followed soon by dewdrops on a rosebud that itch like crazy and can cause scarring if excoriated. The vesicles crop up and then start to cloud over, appearing in different stages at different times. They peak at 3 to 4 days, and they usually crust over by the end of the week. Crusts will fall off in about 2 weeks, and they may leave a little darkened spot for a while, a little bit of a hypopigmentation, and that's usually it. Unless there's a complication. The most common complication in varicella is a nasty superinfection from normal skin flora. Or you may see a group A strep that can wreak focal and systemic havoc. Or you can get a viral pneumonitis or even a bacterial superinfection. The older you are, the more the morbidity. Now, if you can dodge all of that, you're still at risk for varicella-related acute cerebellar ataxia, which can be disabling, but it's often temporary and recoverable. Or you can take your pick from the menu of other options of varicella complications, which include meningoencephalitis, Reye's syndrome, ventriculitis, and hepatitis. Now, that is all if you're lucky enough to be immunocompetent. In the immunocompromised, morbidity and mortality skyrocket. Even if you are vaccinated, herd immunity is only as good as the herd. You may see an attenuated version of chickenpox. It may not be so obvious in the ED. Still, keep your pregnant colleagues and staff away from any child or adult who may have it. Counsel parents on keeping the child away from diabetics, the elderly, or anyone who may be immunocompromised for any reason. We should treat those who are at risk for complications with acyclovir. This includes unvaccinated adolescents who tend to have a harder time with primary varicella, and anyone with a chronic skin or lung disease, and anyone taking oral or even inhaled steroids. So your asthmatic adolescent, for example, is at even higher risk for complications in varicella. That post-Kawasaki kid who is taking aspirin should have acyclovir to attenuate his chance of getting Reye's syndrome. Anyone who's immunocompromised needs IV acyclovir as an inpatient. They are just too high risk to send out. So, what could be a benign self-limiting disease in most people is a game of Russian roulette for others. Chances are in your favor that you'll survive, but if you had a safety on that gun, a good immunization program, why wouldn't you use it? The pneumococcal vaccine has revolutionized the acute care of children. Prior to the vaccine, invasive illness was not uncommon, and our approach to the febrile neonate and infant was extensive and aggressive. We're relatively lucky now, believe it or not. Now, Streptococcus pneumoniae is a ubiquitous bacteria. It's not like the other viruses we've talked about that we could potentially eradicate. Strep pneumonia will likely always be with us, so vigilance for invasive strains is important. There are different valencies of the vaccine available, and some high-risk individuals will be vaccinated against more serotypes. For example, in the US, the current pneumococcal conjugate is now the 13-valent vaccine, an upgrade from the 7-valent vaccine we had previously. Children with sickle cell disease or other types of functional asplenia, those who can't fight off encapsulated organisms, will often get the 23-valent vaccine. We have the best data on the 7-valent vaccine only because that's the version that we've had for quite some time. We can infer some of this data to apply to the current 13-valent version. Since the introduction of the pneumococcal vaccine, there has been a significant decline in invasive pneumococcal disease by 90%. In one retrospective cohort study by Greenhow et al. In children aged 3 months to 36 months, the annual incidence of pneumococcal bacteremia declined from 74.5 per 100,000 children to 3.5 per 100,000 children. This is one of the reasons that we can treat febrile children 3 months of age and older differently from younger infants. You get your first pneumococcal vaccination at 2 months, and after about a month of the immunogenic effect, the vaccine has worked properly, and your risk of invasive bacteremia declines dramatically, even after 1 dose. Healthy children get the pneumococcal vaccination at 2 months, 4 months, and 6 months of age. Ideally, there's a 4th vaccination at 12 to 15 months. There are a lot of considerations with children with special conditions or those who need to catch up on their immunizations. For our purposes, the message to parents who may use the ED as primary care is this: your pediatrician needs to see you when you're well and when you're ill. There are things that we just can't provide for you in the ED. A proper adherence to vaccine schedule is just one of them. The vaccination can cause a local reaction. It can look like a bad bee sting or even a cellulitis. Very rarely, it can be a cause of anaphylaxis, serum sickness, or seizures, but these are so rare and they are so treatable, especially in comparison to the invasive disease. Pneumococcus, of course, also causes pneumonia, otitis media, sinusitis, conjunctivitis, meningitis, osteomyelitis, septic arthritis, endocarditis, pericarditis, cellulitis, and the occasional brain abscess. An important picture to paint for those who hesitate to vaccinate. Polio is another ancient disease. The first recorded case was on an ancient Egyptian stele 3,500 years ago. Polio is a scourge on humanity, causing at best lifelong disability and at worst death. We've come a long way since then. The polio vaccine has helped us in developed countries all but wipe it out. Unfortunately, polio is still endemic in sub-Saharan Africa as well as in parts of Asia. Now, we live in a global society. You may work in an endemic region, or you may receive patients from there, or you may see those who have suffered the sequelae of polio. I'm not holding my breath to see my first case of acute polio. I hope I never do. What we should focus on is what to expect from the vaccine and what we may see in someone after polio has changed his life forever. Most of us are familiar with the injected, inactivated poliovirus vaccine. It contains no live virus, only immunogenic particles. The advantage to this is that there is no risk for contracting the vaccine-associated polymyelitis. The downside is that this vaccine is not as efficacious as the live attenuated virus version. The inactivated polio vaccine is the standard in developed countries where polio is not endemic. The oral vaccine is a better choice for resource-limited areas because it's easy to administer. Just drops on a sugar cube, and it's very efficacious. It promotes mucosal immunity from the wild-type polio virus, and it causes children to share the attenuated virus amongst themselves, so that even if you haven't had the opportunity to be vaccinated, your playmate has, who will give you the attenuated virus and the gift of lifelong immunity. With the standard injected inactivated vaccine that we use in developed countries, the most common side effect is a transient local reaction with erythema, pain, and duration. Nothing a little acetaminophen and cuddles won't cure. The post-polio syndrome may be seen in survivors of polio. We see adults occasionally with this, and you may see immigrant children who have suffered the consequences. In polio, there is a progressive denervation of motor neurons, causing paralysis and often respiratory failure. After a few weeks, you've reinnervated your respiratory apparatus, but the other skeletal muscle takes time. The problem with the reinnervation process after polio is that it's chaotic. You get collateral sprouting. Your wires are splayed in different non-anatomic and non-physiologic ways. You'll never be as strong as you once were, and sometimes your motor neuron units are so dysfunctional you have a functional paralysis of an extremity. Polio never dies. It stays in your nervous system. You can have a slow burn in function over your lifetime, or a recrudescence if you're physiologically stressed, like an acute illness. If you're lucky with post-polio syndrome, you're just always fatigued and generally weak. If you're unlucky, you may have bulbar symptoms like dysphagia and dysphonia. You may even develop central apnea, requiring permanent mechanical ventilation. In the developed world, we can easily forget the blessings and bounty we have. Freedom from the ancient scourge of polio is just one of them. Not everyone is so fortunate. Haemophilus Influenzae, H-flu. The vaccine against it is another triumph in medicine. H-flu only occurs in humans. It's transmitted by respiratory droplets from person to person, and the young just so happen to be its prime target. By the time you're a toddler, you probably have been colonized by both typable and non-typable H. influenzae in your nasopharynx. It can last for some time, and that's probably all right, as long as it doesn't go invasive. Haemophilus influenzae, when invasive, can cause cellulitis, osteomyelitis, and septic arthritis. You get off lucky with horrendous otitis media or conjunctivitis or sinusitis. Or you can be very unlucky and develop life-threatening epiglottitis. If you see a drooling toddler or school-age child with respiratory distress who is under-vaccinated, be very careful. You don't want to pin him down, open his mouth, and gag him for a good look. You want to put him in a position of comfort, pre-oxygenate him, and get him to an operating room where he can be induced with an inhaled anesthetic, and then later an IV is placed and his airway can be taken over. Agitating him in any way can cause functional airway obstruction and hypoxia. If he arrests in front of you, by all means take over his airway, but a steady, gentle hand at this may avert disaster. The bigger problem with H-flu and other vaccine-preventable illnesses for that matter is that we can't predict what unvaccinated child will get invasive disease. H-flu often starts just like a cold, low-grade fever and rhinorrhea. Beware of the run-of-the-mill cold in an unvaccinated toddler. It just may be Haemophilus Influenzae, and it may just go invasive, causing critical illness. Or he may develop life-threatening airway compromise with rapid deterioration. Beta-lactam antibiotics like amoxicillin are the preferred agents. There does exist, however, a beta-lactamase negative ampicillin-resistant H. influenzae strain. Luckily, this pathogen is under 5% of species cultured, but beware also of even the vaccinated toddler who doesn't respond to what should be a simple otitis media. Ceftriaxone is still a potent agent against this troublesome variant. The vaccine works. Since the introduction of the H. influenzae B vaccine in 1985, incidence of invasive disease has dropped dramatically. What used to carry a 15% mortality now is hardly ever seen in vaccinated children. I remember being taught how lucky we were not to have to deal with H. influenza as a consideration for a febrile infant or toddler. But that was before the anti-vaccination phenomenon. Fever well appearing in a vaccinated infant or toddler? Oh, it's not going to be the dreaded invasive H-flu. Croup or some early pharyngitis? It won't be epiglottitis. Times have changed. Be vigilant. Influenza, like, say, varicella, is often a self-limited disease, and if you're lucky, you'll be all right. The problem is that influenza is also spread by droplets, and fomites survive on surfaces for days. Influenza is not benign. It can be devastating to the vulnerable populations we talked about earlier. We choose to participate in vaccinations as a basic agreement to live in a civilized society. It's not just for the individual as much as it is for all of us around us who can't be vaccinated or those who won't do well if infected. We can't pick and choose which laws we want to follow. We can't decide on the fly to follow some traffic laws and not others. Living among other human beings has its perks, like electricity, running water, and basic security, but it also has its obligations, like a thoughtful and mutually accepted behavior and agreement. One of them is the obligation not to contribute to the promotion of pandemics. Influenza is the ultimate infectious secret agent. It spreads stealthily even before you know it's there, and when it comes, it's too late to do much of anything. Influenza has so many disguises and forms that it's impossible to predict what alias or form it'll take when it strikes. The attack rate of influenza on children will vary depending on its particular alias or particular season. Up to 40% of children can be affected by it during its peak season. In otherwise healthy children, this will account for a lot of unnecessary outpatient visits, for overuse of antibiotics, and for many, many missed work days by parents caring for them. You've seen it before. Fever, headache, cough, sore throat, myalgias, sometimes accompanied by abdominal symptoms. The presentation seems to have a little different flavor each year. Usually you start to get better over the course of a week, regardless of your use of antivirals, which only seem to consistently cause nausea, vomiting, and nightmares. The cough may linger long after the acute illness has passed. The parent may bring the older child or adolescent back to the ED a few times over the next few weeks because of easy fatigability and prolonged malaise. This is called post-influenza asthenia. It's not teenagers being teenagers, it's a preventable syndrome. Just when you think you're getting over your flu, you can get a new infection with another influenza subtype. I mean, look at it this way. You have some viral suppression of your bone marrow, you're probably a little dehydrated or undernourished, and another subtype of influenza finds an easy victim in you. The myth is that you can only get flu once a year. Other complications of influenza include pneumonia, otitis media, or croup. Rare complications include encephalitis or myocarditis. Now, all of this applies to healthy, older children. Deaths occur with influenza. A big risk factor for this is age. Children less than 5 years of age, especially those less than 6 months old, have a higher mortality rate in influenza. Young children, well enough to go home, should have close follow-up and return precautions. Other conditions that increase mortality risk include chronic pulmonary disease, so even your asthmatics have that risk factor. Any renal, hepatic, cardiac, metabolic, or neurologic disorder. So basically any child with a chronic medical condition you can apply this mortality risk factor to. Remember the immunosuppressed, and also remember pregnant women or even those in the pubertal period. The flu is rampant. You may be able to avoid it. You'll likely be able to avoid all that goes into caring for someone or worrying about someone who has it. The vaccine is available. It's inexpensive. Do yourself a favor and everyone around you and vaccinate every year. If you thought the previous dozen vaccine-preventable illnesses were scary, let me introduce you to the last of the dreaded 13, Meningococcus. Our arch enemy, Neisseria Meningitidis, has a mortality rate of nearly 15%. And it's also wily. It might cause meningitis. It might cause meningitis and meningococcemia. Or it might manifest only in the blood. It may present as meningococcemia only. Meningococcemia keeps us up at night. A quarter of the population carries it asymptomatically in their nares. And when it becomes clinically pathogenic, at first it looks like a cold or the flu, rhinorrhea, fever, myalgias. Or it may look like febrile exudative pharyngitis. Strep throat is often a common misdiagnosis here. But it doesn't stop there. The myalgias are intense. Some children have just deep, bony pain and fever. It's not a virus. It's meningococcus. The child may appear well enough to go home when you see him initially. Hours later, he develops purpura and shock. I'm talking hours, less than half a day in some cases. We should always think about meningococcus when we see a child with an acute complaint of any of these: leg pain, cold hands, pallor or mottling. Don't think that if there's no petechiae or purpura, you're safe. Do a really good physical exam. General appearance is always important, but it may fool you. Look for capillary refill. Check every centimeter of skin, especially areas that are prone to light pressure like elastic waistbands or diaper lines. Petechiae often manifest here first. Purpura fulminans may be the first presentation. It occurs in up to a quarter of children with meningococcemia. There's pain, then erythema, then petechiae from thrombocytopenia and DIC, all from the hematologic chaos caused by the bacterium. You may see accompanying meningitis, or myocarditis and heart failure. The younger you are, the more likely that you'll die from meningococcemia. Fortunately for everyone, Neisseria Meningitidis is almost always susceptible to a third-generation cephalosporin like ceftriaxone. The first critical action is to suspect it, followed by the second, rapid administration of ceftriaxone. Close contacts should receive chemo prophylaxis. Who's a close contact? In the healthcare setting, really no one other than the person who managed the airway, but we've all seen the hospital staff line up when they've heard about a case. A close contact is someone who's had prolonged contact, so greater than 8 hours of casual contact in close proximity, defined as less than 3 feet. This includes household or family members, roommates, childcare participants, dormitory residents, and military recruits. The duration rule flies out the window when there is intimate oral secretion contact. Again, hopefully for our purposes, that's just managing the airway. Chemo prophylaxis is the most effective when it's given immediately, so less than 24 hours after exposure. Reported cases of secondary meningococcal disease have all occurred within 10 days of exposure. The CDC recommends 14 days as a cutoff for prophylaxis. You can use rifampin or ciprofloxacin. Rifampin is superior in some studies. Rarely, there are outbreaks of cipro-resistant meningococcal disease. But of course, when all else fails, an IM shot of ceftriaxone is the nuclear option. Ciprofloxacin becomes the happy medium because almost everyone can take it. A single dose will do you. Since meningococcus is really about close contact, and most preschool children are not, in school, the vaccination schedule for healthy children starts as a preteen and continues through adolescence. For children with functional asplenia like those with sickle cell disease, Neisseria Meningitidis is one of our encapsulated friends, and vaccination may start as early as 2 months of age. There are a few factors that go into this, including functional versus asplenia and the consideration of when pneumococcal vaccine will be given. So again, another reason in general to repatriate all well children back to their homeland pediatrician for better continuity of care. Okay, it's a busy shift. You're running from room to room. You're taking care of some critically ill patients and some who are not so critically ill. As you're going through some of your usual questions in your history, you find a family or two or more today who have not been vaccinated. They have a lot of questions. Let's try to answer their questions with simple, non-jargon, straightforward language.
What are the side effects of the vaccines? How do I treat them?
Vaccines, like any medication, may cause some side effects, but most of these side effects are very minor, like soreness where the shot was given, maybe some fussiness or low-grade fever. These side effects typically only last a couple of days and they're treatable. For example, you can apply a cool, wet washcloth on the sore area to ease the discomfort. Serious reactions are very rare.
Is there a link between vaccines and autism?
No. Scientific studies and reviews have continued to show no relationship between vaccines and autism. Some people have suggested that thimerosal in vaccines given to infants and young children could be a cause of autism, and some have said that MMR could be a cause, but numerous scientists and researchers have studied this, and they continue to study the MMR vaccine and thimerosal, and everyone has reached the same conclusion. There is no link between them and autism.
Can vaccines overload my baby's immune system?
Vaccines don't overload the immune system. Every day, a healthy baby's immune system successfully fights off thousands of germs. Antigens are parts of a germ that cause the body's immune system to go to work. These antigens in vaccines come from the germs themselves, but the germs are either weakened or they're killed so that they can't cause serious illness. Even if babies receive several vaccinations in one day, vaccines contain only a tiny fraction of the antigens that they encounter every day in their normal environment. Vaccines provide your child with the antibodies they need to fight off the serious illnesses that they're getting vaccinated for.
What do you think of delaying some vaccines or following an alternative schedule?
Children don't receive any known benefits from following schedules that delay vaccines. Infants and young children who follow immunization schedules that spread out their shots or even leave out some shots are at risk for developing diseases during that time that the shots are delayed. Some vaccine-preventable diseases remain common in the U.S., and children may be exposed to these diseases during the time that they're not protected by vaccines, placing them at risk for a serious case of the disease that might cause hospitalization or death.
Haven't we got rid of most of these diseases in this country?
Some vaccine-preventable illnesses like pertussis, so whooping cough, and chickenpox remain pretty common in this country. On the other hand, other diseases prevented by vaccines are no longer common because of the vaccines. If we stopped vaccinating, the few cases that we have could very quickly become tens or hundreds of thousands of cases. Even though many of these serious vaccine-preventable diseases are uncommon, some are common in other parts of the world. And even if your family doesn't travel internationally, you could come into contact with international travelers anywhere in your community. Children that are not fully vaccinated are exposed to disease that can make them very sick, and then they can spread it throughout the community.
Don't infants have natural immunity? Isn't natural immune better than the kind from vaccines?
It is true that babies get some temporary immunity, so some temporary protection from mom during the last few weeks of pregnancy, but that's only for diseases for which mom is immune. Breastfeeding can also protect your baby temporarily from minor infections like colds, but these antibodies don't last long. Natural immunity occurs when your child is exposed to disease and then becomes infected. And it's true that natural immunity usually results in better immunity than vaccination, but you get sick and the risks are so much higher. A natural chickenpox infection can result in pneumonia, so the vaccine can just cause a little bit of sore arm for a few days.
My child is sick right now. Is it okay for her to still get shots?
Yes, you should talk to your doctor, but children can usually get vaccinated even if they have a little mild illness like a cold or a mild fever. I hope that all of this has been helpful. in making us more familiar with these vaccine-preventable illnesses. Remember, vigilance, patience, and advocacy. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.